Onc Live Insights is a video editorial program produced by Onc Live.
So in the era before the novel inhibitors, for those patients who did not have 17p deletion and had a reasonable duration of response to chemo immunotherapy, we would often retreat them with further chemo immunotherapy. So a patient who had had FCR, who responded for an extended duration, might then get BR. In the United States, given the data with ibrutinib, there's really been a marked transition where almost all relapsed patients, with or without 17p deletion, are generally treated with a novel agent, typically ibrutinib first, unless they have a contraindication such as requiring anticoagulation, having a bleeding diathesis, or having cardiac disease, in which case one can use idelalisib. There is some debate between US and European investigators as to whether it is appropriate to still use chemo immunotherapy for those patients who had frontline chemo immunotherapy with a long response duration. And in fact, there are some patients who say, I got 6 years from my FCR, can I get 3 cycles of a chemotherapy regimen and be done for 4 years, rather than taking a pill continuously for 4 years? And so as long as those patients are not high cytogenetic risk or with short response duration, that is potentially reasonable. But in the absence of that specific preference for the patient, we typically move to the BCR pathway inhibitors. I usually use ibrutinib before idelalisib because of its more favorable side effect profile.
The incorporation of the new BCR inhibitors are mainly in the setting of relapsed refractory CLL. Of course, there is many situations where patients with chronic lymphocytic leukemia relapse, maybe after 1 line of therapy, 2, 3, or even more lines of therapy. Most of the patients currently have received at least, in most of the time, 1 chemo immunotherapy treatment in the form of FCR or in the form of BR, or even in the form of Rituxan chlorambucil in the recent times. In these patients, I believe that BCR inhibitors in patients who are not really candidates to receive further chemoimmunotherapy are the best options to really start therapy based on the prolonged progression-free survival that really are being demonstrated in multiple clinical trials. The use of BCR inhibitors, mean ibrutinib or idelalisib, I really think is the main therapeutic options that people with relapsed refractory CLL are having these days. Most of these people already have received some form of chemoimmunotherapy, such as fludarabine Cytoxan Rituxan, or bendamustine Rituxan, or even other combination of chemoimmunotherapy. In this group of patients, and independently of the lines of therapy, 1, 2, or even more than 3, these drugs, these targeted therapies, such as ibrutinib or idelalisib, in my opinion, are excellent choices as they produce a very long progression-free survival, and independently of the comorbid condition and the toxicity of each drug, may be more suitable for a certain population of patients. So the use of chemoimmunotherapy in relapsed refractory CLL, I think, is less and less used, at least in the US practice. And this is because the incorporation of the more convenient and easy to take oral available targeted therapies. However, there is situation where these oral therapies cannot be tolerated by the patient, or they're being tried and they have to be discontinued because different side effects. In this situation, chemoimmunotherapy in the form mainly of bendamustine Rituxan at dose reduction in the bendamustine to 70 milligrams per meter square or even 50 milligrams per meter square may be a reasonable approach for those patients in which targeted therapies are being tested or are not being, cannot be used secondary to drug-to-drug interaction or comorbid condition that won't allow the use of these drugs.
So it's become much less common to treat relapsed refractory patients just with antibody therapy. I have never used rituximab in relapsed patients because its response rate is generally poor at the 10 to 15% level. You can use dose-dense rituximab, which may have a somewhat better response rate, although in my experience, usually durability is short. Ofatumumab has more activity in patients who are not as refractory to fludarabine and alemtuzumab, i.e. its labeled indication. That being said, obinutuzumab, based on the data from the upfront study, I feel is generally a more potent antibody, so I would probably go toward obinutuzumab if I were going to try a single-agent antibody. But this is not something common because I'm usually using a novel inhibitor. Alemtuzumab has a somewhat checkered history. It is actually a very potent drug against fludarabine refractory or 17p deleted CLL in blood and bone marrow, but it doesn't have a lot of activity in lymph nodes. And so in the past, before we had novel inhibitors, many patients would not do that well because they had large lymph nodes that didn't respond. But the subset of patients who had mostly blood and marrow disease would often have a phenomenal response and could be retreated many times. My use of alemtuzumab now is very limited compared to what it was before, but I would consider using it to, for example, complete clearance of the bone marrow in a high-risk patient who we were trying to get to transplant.